patients in different clinical conditions, main contraindications, and adverse effects. Then the clinical relation, the approach to an arrhythmia, and maybe if we have some time, we'll discuss a few special scenarios. Okay. Okay, so arrhythmias are very common in the ICU. You would have seen if you have been working in an ICU, about 1 in 2 patients might get an arrhythmia depending on the clinical condition. So predominantly the arrhythmia we see in the ICU is atrial fibrillation. Out of the arrhythmias, about 2/3 is this, other than other arrhythmias which could be related to their clinical condition, especially if they are with a cardiac condition. So these conditions increase the length of stay in the ICU and of course the mortality and morbidity of critically ill patients because they are associated with reduced cardiac output. So they themselves will increase mortality. Antiarrhythmics, when we consider the pharmacology, they are classified according to their clinical or electrophysiological effect. So you'd have heard about this VW classification, which we were taught during our medical school days. So it's the same. There had been a bit of modifications here and there, but not basically changed. Most have multiple modes of action. So they that is why we need to be very thorough with the actions of commonly used drugs because they can have other modes of action also. Okay. However, even though we classify according to this VW classification, most commonly used newer agents are incompatible with this classification. You would see a lot of drugs in this classification are now not in clinical practice. As I said earlier, there are a lot of adverse effects associated with these drugs. So you need to be mindful when you are using these drugs on critically ill patients because they are on lot of other drugs which can give rise to reactions and potentiated adverse effects. So you would agree with me, amiodarone is the most commonly used drug for arrhythmias. Obviously, it's for tachyarrhythmias. And if you consider the patient to be hemodynamically unstable, you have to opt for electrical cardioversion or pacing in bradyarrhythmias. So if you opt for electrical cardioversion, it needs to be followed up with drugs, obviously. So we'll briefly discuss when we use electrical cardioversion. If you have done your advanced life support course, local course, or the ERC course, you would know when to use electrical cardioversion and when we consider a patient to be unstable with a tachy or bradyarrhythmia. There are 4 instances, and in the newest classification, there is a 4th indication to give ECV. So if I just mention it here itself, the factors which are considered the patient, which determine the patient's instability are, number 1, syncope, if the patient has syncope. Number 2, ischemic chest pain. Number 3, it's heart failure or pulmonary edema. So you have to see all these features clinically and in investigations wise in a quick assessment to check if your arrhythmia is unstable. 4th is hypotension, systolic blood pressure less than 90 or otherwise shock. The 5th in the newest guideline, they mention, but they haven't included it in the flow chart, but they have mentioned in the guideline if the arrhythmia, for example, if the tachyarrhythmia is in its extremes, like if you have your heart rates going up to 280s, 250s, I mean more than 200s, itself is an indication for ECV, not the first 4 which had been there for some time now. So if the arrhythmia is extremely high in the rate, you can straightly go for ECV without considering drugs as the first choice. So Having said that, we have to always sort the underlying cause for the arrhythmia. It should always be sought actively and corrected, because you might not correct it with the drugs if the cause is persisting. For example, sepsis, the commonest cause for arrhythmias in ICU, underlying cardiac conditions, underlying lung conditions, your electrolyte abnormalities, the drugs, interactions of the drugs, and other metabolic and endocrine causes like thyrotoxicosis, hypothyroidism, and other metabolic diseases. You should remember that all of these drugs are pro-arrhythmic. That's why we said they have multiple modes of action. You might be using one drug for this arrhythmia, but it might cause another arrhythmia. So this you have to be mindful. And when you're reassessing the patient for a changed arrhythmia, you have to always consider what drugs he or she is on, because that could be the reason for the new arrhythmia. Right, we move on to the second part of the lecture, the physiology of cardiac conducting function. So all of us have learned this in our physiology. So the heart has a specialized conducting system. That's why we have a sinus rhythm. So sinus rhythm starts at the SA node, and via the atrial conducting tissue, it goes to the AV node, atrioventricular node. So sinoatrial node is the one which triggers on its own spontaneously to give rise to a sinus rhythm. It travels through the atria to AV node and the bundle of His, through the bundle of His into the Purkinje fibers into the ventricles. That is the flow of electrical activity. All this whole system comprises of cardiac cells which are electrically excitable. It's a specialized system. The cells have voltage-sensitive plasma membrane channels selective for these ions, sodium, potassium, and calcium. So in and out movement of these ions dictate which way the current flows. So where we stand in the cardiac electric potential. Further, the electrophysiologic features specific to cardiac cells are, there are few cells which have pacemaker activity, for example, SA node predominantly or AV node in some instances. Absence of fast sodium current in SA and AV nodes. So these are the pacemaker tissue. They don't have fast sodium current. So that's what differentiates them from the other parts of the electrically excitable tissue. They have slow inward calcium currents, which initiates the action potential. So when we move into the action potential, you will understand this. There is a the slow inward calcium current is what they have. So apart from the other tissues, they have long action. I mean, this is how they are specialized. There's a long action potential, which we call a plateau, and then there is a refractory period. So this is in comparison to the neuronal tissues. As well, there is an influx of calcium during plateau. These points you could be asked at your MCQs. Right. So what are the sodium and calcium currents? We'll talk about the calcium channels. So calcium channels are situated in the plasma membrane of these cells. They are voltage-dependent L-type ones. We can find it in the cardiac conducting system, the contracting myocardium, myocytes, and as well in the vascular smooth muscle. So these L-type channels are found in 3 different tissues in the body. That is the plasma membrane associated channel. Intracellular calcium channels are responsible for myocardial contraction only. So they are ryanodine receptors, also known as inositol triphosphate, ITP activated calcium channels. So this is the common picture we saw in the popular picture we saw on Ganong, the cardiac action potential. It has 4 phases: 0 phase, phase 1, phase 2, phase 3, and phase 4. What is phase 1? What is phase 0? That is, just remember the names in this slide. This is rapid depolarization. This is where the action potential propagation starts. There is rapid depolarization of the cardiac excitable tissue membranes. Then plateau, 1 is the partial repolarization. There is the membrane potentials The one which went up very suddenly dips a bit. That is, if this is depolarization, this is repolarization. So there's a little bit of repolarization, partial. We'll talk why it happens. And then you have the plateau. And then the full repolarization. The action potential goes down below the level which it started. And then it again goes to the baseline, which is the pacemaker depolarization. So wherever the line goes up, there are depolarizations. Wherever the line goes down, there are repolarizations. Whenever the line stays relatively flat, it is the plateau. Okay. So you just need to see how this cardiac action potential tallies with your ion currents, the ECG, and what happens in different parts of the heart. The action potential morphology changes at different sides of the heart because the SA node doesn't have a plateau. See, AV node doesn't have a plateau. The generic action potential is the one which is generated in the ventricles. If you can see, this is the Purkinje fibers, which are the ones which transfer the action potential into the cardiac muscle and the ventricle. So this is what we consider as the generic action potential morphology. Just watch this video. Can you hear? Can you hear the video sound?
No,
Hello.
madam, we didn't hear.
You can't hear, right? Not sure how to make. Can you hear now? Can you hear now?
No, not yet, madam.
Were you able to hear then?
No.
Do you hear it? No, not at all.
No, no.
Right. So just see, without the voice, you can just see this is just a graphical representation on how to. Let me explain while it goes, okay? Right. So this is the myocardial action potential. We talk about this phase 0. It is rapid depolarization. So what happens there? Sorry. So in rapid depolarization, what happens is the plasma sodium channels open. They are fast sodium channels. Okay. So the fast sodium channels in the plasma membrane opens. So the sodium channels seep through the channels into the cell. So there is influx of sodium ions through the fast sodium channels in the plasma membrane. So remember that fast sodium, phase 0. So this is what happens. Outside sodium channels come into the cell. So this is rapid repolarization. What happens there? Again, another channel opens. What happens there? So there is potassium channel opening. So potassium goes out. Sodium in. That is why the positive charge within the cell increases. But then when the potassium channels open in the phase 1, positive charges go out. That's why it becomes repolarized. So during this potassium movement, the first channels which were open, the fast sodium channels, they close. So there is no inward movement of sodium at the phase 1. So remember, in phase 0 and phase 1, there is no calcium. It's sodium and potassium. Sodium in, potassium out. Now comes the plateau. Okay. Now the calcium channels open. So while the potassium is going out, so the amount of potassium which goes out is balanced by the calcium channels which are in. That's why there is no change in the potential. If you can remember like that, you won't forget. So massive sodium influx, little bit of potassium out, and the potassium channels are kept open. So while they are open, the calcium channels open also. So potassium out, slowly it's going out. To balance that, calcium is again coming in. That's why the potential is plateaued. What happens is this potassium thing never stops. Calcium opens, and at the phase 3, calcium again closes. Then what happens? There is net efflux again. What happened? At the phase 1, it's again happening. It was balanced in the phase 2 by the opening of calcium channels, but in phase 3, it doesn't happen. So potassium out, rapid repolarization. This is what generates the current. Okay. Then in the phase 4, there is again depolarization, but this is not the fast sodium channels, but slow sodium channels. So there is a little bit of potential increment due to slow sodium channel opening. So this movement of sodium prepares the cell for the next action potential to occur. Right? So that is the cardiac action potential explained as by ion channel opening and closure. Right. So how do we get abnormalities? So we know all this. Commonly there are 4 things which have been described, but there are a lot of other things, and these 4 can occur simultaneously. So the main 4 are delayed after depolarization. What is depolarization now? That is the phase 1, rapid depolarization. So after depolarization, if the phases after depolarization are delayed, so the action potential drags. So that is one explanation. Re-entry systems. Now the action potential comes back due to some abnormality. So re-entry. Ectopic pacemaker activity. For example, in AF, in ventricular ectopics, the other tissues take over the sinoatrial node so that you can get ectopics, your fibrillations. So that is one, the third way, or heart blocks that results in bradyarrhythmias. So we'll not go into details of how it happens because it might take a lot of time. You can just remember these four and then read upon that how it happens in details. Right? So these are the ways in which the arrhythmias happen. So we'll move on to the drugs, antiarrhythmics. So this is the VW classification. So make it simple. Don't try to grab everything which a textbook gives. Just be clear in your mind what happens and fill in the gaps. Just make a mesh of knowledge for one topic and then try to fill in the gaps. Otherwise, you wouldn't be able to by heart everything which a chapter gives you. It applies a lot in antiarrhythmics. So if you go through the VW classification, there are 4 classes. Class 1, 2, 3, 4. Nomenclature is in Romans. And the class 1 further divides into 3 categories, A, B, C. Right? So what are 1A, 1B, and 1C? Just remember they are sodium channel blockers. Okay, sodium channel blockers. How do they differ to each other? So the drugs are disopyramide. Have you used it on any of the patients? No, I haven't. Flecainide, I've heard that it was used, but I haven't. Lignocaine, yes. So remember class 1, A, B, C. B is the one we use commonly. Maybe out of the 3, we use lidocaine commonly. So all of them are sodium channel blockers. So just remember it with your action potential, right? So sodium is 1. 1A is intermediate dissociation. These are intermediate acting blockers. 1B are fast acting blockers. 1C are slow dissociation, slow channels. Slow channels, fast, so slow action, fast action, and intermediate action. So these 3, 1 done. 2, 3, 4, the ones you know, the common ones. 2 is your beta blocker. 3 is your amiodarone and sotalol. So sotalol being the name suggests a beta blocker, but they are potassium channel blockers. Okay, amiodarone, potassium channel blockers. 4 is your CCBs. So easy to remember, right? So the ones which we use a lot, but unclassified in VW system. There are a lot of other drugs we used, right? Adenosine, we use a lot, right? And we use a lot of atropine. We use a lot of isoprenaline, digoxin. None of them are in this classification. Just remember, there are a lot of drugs which are not in the classification. Right. So which part of the action potential do they act? As I said, class 1 are sodium channel blockers. So they act in the phase 0, rapid depolarization. Right? In your plateau, the calcium channel blockers. That is where the calcium channels are highly active. So remember with this, CCBs, sodium blockers. Class 3, potassium channel blockers. So this is where potassium goes out very fast and not all of them. So when we block that, we can get a huge action. So that is where your potassium channel blockers act. Amiodarone and sotalol. Sodium, calcium, potassium. And after the last phase, where the action potential goes back to the baseline, that is blocked by beta. That is basically what are beta blockers? They block your sympathetic outflow. So basically, they make the action potential to reach the baseline. The time taken by the action potential to reach the baseline, they prolong that time. That is what beta blockers do. So remember this, so you remember it for life. Right? So this is again the same thing. So we'll take class 1 drugs. What is the mechanism of action? We all know by now, sodium channel blockage. right? So they bind to the sites on alpha subunit of these channels. They inhibit propagation of action potential in many excitable tissue. They are called membrane stabilizers. All of these are just literature. They have put some name, so they are membrane stabilizers. Why we call it a stabilizer? Because it prevents the membrane getting depolarized. Excitability is reduced. It reduces the maximum rate of depolarization. So this diagram, if you pay attention to, the black is the normal action potential. And when we use the class 1 drugs, it reduces the amount of depolarization it reaches. So let's say it reaches, in normal patient, it reaches 50 millivolts. This can reduce the amount of depolarization it can reach, right? So these things you can remember with the action potential morphology. Okay. So they give a use-dependent channel block, we say. Right? So sodium channels can be resting, open or inactivated. And then during the rapid depolarization, they switch rapidly from resting to open position. Class 1 drugs bind to these channels more strongly when they are in open or inactivated state. So in any of the state, they can bind well. But in resting state, they bind less avidly. So when you use these drugs, it can act on some patients and not in others. Right? And it shows use dependent. So this is what use dependence means. Use dependence is that it blocks the high frequency excitation of myocardium that occurs in tachyarrhythmias without preventing the heart beating at its normal frequency. So it doesn't make the heart bradycardic. That's what we saw here, right? It just reduces your size of your action potential. It doesn't slow your heart. What are the 1A drugs? These are the oldest group of drugs. Includes quinidine, procainamide, disopyramide. None of them are in common use these days. So even though we call it 1A, when we consider the action or the properties, they lie in between 1A and 1B and 1C. Right? So class 1A is this red bar. So it reduces your action potential. We'll compare with 1B and 1C later when we discuss about them. Apart from this reduction in depolarization, the size of the depolarization, it prolongs repolarization. It has an additional action. So we said that there are different modes of action. The primary mode is this. There are additional modes. In 1A, it is that it prolongs repolarization. This potassium channel opening is prolonged for some reason. That is a minor action of 1A drugs. With that, it increases the action potential duration. So this might slow down the heart at some point, right? Individual 1A drugs are mainly historical. Pharmacologically, they are similar. So we will not go much into it, but quinidine is an anti-malarial drug. So that is why we need to know there are other indications of these drugs. Even though we don't use it for anti-arrhythmic function, quinidine, you would see a patient on IV quinidine. So they can give rise to arrhythmias, right? Because if you give it to a sinus rhythm patient, the indication being malaria, it can cause arrhythmogenic effects. As well, they say they possess atropine-like effects because of distinct from 1A action. So those are special cases. You don't need to remember these finer stuff. What are 1B drugs? So lignocaine. Lignocaine, we use it when? lignocaine, there is an indication for VTs, right? In ventricular tachycardias, we can use lignocaine. So it is called 1B. It acts on fast sodium channels, right? The action is faster than 1A drugs, right? The importance is it binds selectively to inactivated channels. In 1A, we said active and inactivated both, but resting they won't. So active, inactive is within the action potential. Resting is when it is in the resting potential. Because in this action potential, sodium channels will be inactive or active. This is the phase in which it is resting. Okay. So what does it do? It reduces your action potential as well. It shortens your AP duration. So there is a risk of arrhythmia getting worsened in view of the rate. See? Now 1A prolongs, 1B shortens the AP. Lidocaine we use for ventricular tachyarrhythmias. It has little effect on atrial and nodal tissue. So in VF and BT, after amiodarone, you can opt for lignocaine if it is not responsive to amiodarone. Right? It is given as an IV infusion, and if you have the drug, it's a very effective drug, and you can really try it on patients when you find other drugs ineffective, especially amiodarone. There are resistant VTs, resistant to cardioversion. So patients can be put on lignocaine infusions. 1C drugs. These are also not in clinical practice. Again, it reduces the action potential size, but it doesn't affect the duration of AP. This is how they are classified into 1A, B, and C. So this prolongs your action potential. This reduces the duration of action potential. This doesn't affect class C, 1C drugs. So flecainide, I don't think there is any point in learning about flecainide. We don't use it much. I haven't used it at any point. Right? So if we take, now this is an old book from which, seldom used now, even lignocaine, because amiodarone is a good drug for VT. So out of these three, clinically, what we use a lot is lignocaine, not the other two. Okay, we move on to class 2 drugs, beta adrenoceptor antagonists, beta blockers. Right? So when do we use it? To reduce the heart rate. This is not to reduce the action potential size, but to slow down the heart, especially following MI. So that is a finer indication. That is a recognized indication for beta blockers because it has survival benefits after MI as well. Okay, what it does is that it reversibly blocks beta-1 cardiac adrenoceptors. How do they do that? They increase the refractory period of the AV node. There is a refractory period in the AV node. If you refer to the action potentials at different sites of the cardiac muscle, we had a graph for AV node. So there is a refractory period, and it increases this refractory period, so the propagation of the action potential slows down. So AV node blockage, in other words. Or it directly inhibits sympathetic activity by the beta blockers. So what are the contraindications? In acute heart failure, we don't use it. When the lungs are wet, we take time to start them on beta blockers, even though following an MI, and also asthma, because it is well known to exacerbate asthma because they block the beta blockers in the lungs, beta receptors in the lungs. What are the adverse effects? They can cause hypotension when the patients are on ionopressors. Now, let's say the patient is septic on noradrenaline, vasopressin, and now there is a bit of cardiac dysfunction, we are opting for dobutamine as the third inotrope. Still, the patient runs an AF. So you should be a bit cautious about giving beta blockers to such a patient because it can cause drastic hypotension. So esmolol, metoprolol, and you can give even now oral drugs, bisoprolol, carvedilol, propranolol. So the doses and how to give it, you need to be familiar with. I would explain metoprolol only. Sometimes I don't have any of these beta blockers IV. So metoprolol, the usual dose is 5 milligrams. The rate of 1 to 2 milligrams per minute. But mind you, if you are cautious about hypotension and bradycardia, just try with a 2.5 and then see the effect and then give the rest. Right, so to reduce the mortality following MI, to prevent recurrence of tachyarrhythmia. So AF in young patients, always opt for beta blockers as the first line if you have excluded the contraindications, and be cautious when you are giving it to a really critically ill patient because of the risk of hypotension. Class 3 drugs. What are the class 3 drugs? They are potassium channel blockers. So originally they are based on an unusual behavior of a single drug, amiodarone. So because of amiodarone, this class is formed. And they have found this beta blocker sotalol followed the same, but still it's named as a beta blocker. So both of them have more than one mechanism of action. The main mechanism is it substantially prolongs the cardiac action potential. Why? They block the potassium channels, that is, potassium channels which are involved in the phase 3 of the action potential. You saw it causes rapid repolarization. And when they are blocked, it eventually prolongs your cardiac action potential. So when the action potential is prolonged, your refractory period is prolonged because the other impulse in a tachyarrhythmia, there are a lot of impulses coming at a very fast rate. Once amiodarone blocks the potassium channels and prolongs the cardiac action potential, this refractory period is increased. Refractory period is defined as the period where the second impulse cannot generate an action potential. So the tissue is refractory. It is resistant to the propagation of this impulse. So this refractory period is prolonged. So ultimately, the rate gets slowed. They block potassium channels. So the phase 3. Again, the other modes of action are interruption of reentrant tachycardia. So the mechanisms are really complicated to understand. So apart from blocking the potassium channels, they block the reentrant tachy system. Also, there is an effect to suppress ectopic activity. So ventricular ectopics also, it's a very famous drug to be given orally. Again, they have paradoxical pro-arrhythmic activity. There is a risk of polymorphic VT also, especially in patients with a risk of long QT. So long QT, when they are with a lot of risk factors for long QT, like on other drugs, on some antibiotics, which can prolong your QT. If you give amiodarone to such a patient, there is a risk of pro-arrhythmic activity giving rise to torsades equinitis, polymorphic VT. So be careful when you are using these drugs. Amiodarone is a highly effective antiarrhythmic. It's broad spectrum. It has all class 2, 3, and 4 activity. 2, 1, and 4 activity. Class 2 is under which it is classified. So it blocks in different intensities. It blocks sodium, potassium, and calcium channels, and even beta receptors as well. So the main action is on potassium. So always monitor plasma potassium because it blocks the potassium channel. So always be sure that you have a reasonable potassium to go with. And once you have started it, monitor your potassium. The problems associated with amiodarone is that it gets extensively tissue bound, and you have a long elimination T-half. Takes about 10 to 100 days, they say theoretically. So when you give repeated dosing to patients, it tends to get accumulated in the body. So the drug is given as a loading dose, and it should be given via a central vein. or a large proximal peripheral cannula in emergency situations, but always it's advisable to go with a central line. What are the indications? All hemodynamically stable tachyarrhythmias, including VT. So you name it, we give amiodarone to that arrhythmia. Just remember like that. But if you try to give it to a sort of a VT patient with other risk factors like risk factors for prolonged QT, you have to be very careful. So the common indications are prevention of post-op AF, like especially in CABG patients, cardiac surgery patients, rate control or cardioversion in established AF or flutter. So in AF, it's a very effective drug. Right. So what is the dose? Dose is, as you all know, it's a well-known regime. 300 milligram bolus over 30 to 60 minutes. So usually we give it tailored, like if you want to give it, usually we give it to 1 hour followed by the rest of the 20 milligram per kilogram. So the total dose is 20 milligram per kilogram, 5 milligram per kilogram as a bolus, then followed by 15 milligram per kilogram over the next 23 hours. So you give it within a day. Diluted in 5% dextrose. So once you have given this regime, you have to, most of the time, you will have to put the patient on maintenance dose enterally. Oral amiodarone, you can start with 200 BD, but then go down if you are noticing the heart rate to go down below 60. So the target always asks the nurses to check the heart rate before you give your amiodarone, even the oral dose. It should ideally be like clinically, we give it when the heart rate is well above like 70, 80 margin, never below 70 because it can drastically cause the patient to get bradycardia. Right? Other indications are during the cardiac arrest you give. So just refer your ALS updated guidelines on how you give amiodarone. After the 3 shocks, you give in shockable rhythms likewise. Right. So what are the pharmacokinetics? What the body does to the drug? Delayed onset. So it takes about 6 to 8 hours. This is oral. And it has hepatic metabolism. No adjustment of doses needed in dialysis because it's not renally, it's hepatic metabolism. Okay, so you have to especially be careful about prolonged QT with some antipsychotics, antibiotics, antifungals, and other antiarrhythmics. When you combine antiarrhythmics, it's really important to be vigilant about proarrhythmogenic effects. So what are the adverse effects? It is known to cause a lot of adverse effects when the patients are put on long-term amiodarone. However, even in the IV preparation form, it can cause adverse effects. So what are the common ones? And the deadly ones are your deranged liver function tests. Amiodarone can cause hepatic impairment, pulmonary fibrosis, and thyroid abnormality. Very common thyroid abnormalities. They either can go into hyper or hypo, extremes of those two. So be careful when you put them on amiodarone long term, and always when a patient on long term amiodarone comes to ICU, vigilantly look for these abnormalities, especially when they get these abnormalities. Consider amiodarone that it could be a cause for all this. Sotalol, I wouldn't go into details. Right. Class 4 drugs, calcium channel blockers. They act on the plateau. So they block voltage sensitive calcium channels, the L-type ones. They are diffusely present in the myocardium. By that, they slow down the conduction in SA and AV nodes. They slow down the heart rate, terminates SVT by causing partial AV block. So all of this shorten the plateau. So that is how they act. And other actions are this phase 4. Phase 4 is by slow sodium channels, right? So they have combined effects. Mainly it is the calcium and the plateau. Indications, calcium channel blockers are in the algorithm for SVTs, right? And in AF as well. PCBs, beta blockers, amiodarone, all of them can be used in supraventricular tachycardias, right? What are the adverse effects? And where would you avoid calcium channel blockers, especially if the patient has a history of second and third degree heart block? And if you combine this with a beta blocker, always be cautious about bradycardia and hypotension, as we talked about. As we talked when we were mentioning beta blockers, hypotension is a known adverse effect. So make sure that you monitor the patient very carefully. What are the drugs? Commonly, the antiarrhythmic calcium channel blockers are verapamil. And what is the other drug? The diltiazem. They can be used as antihypertensives, but verapamil is a very well-known and very effective antiarrhythmic. So verapamil, do we give it IV? Yes, we can give it IV, but enterally as maintenance, it is used very commonly, right? But IV preparation, you have to give it not in a ward. So verapamil, we do give it in the ICU. So when you need it, don't be afraid to use it. Plasma T half is around 6 to 8 hours. It gets metabolized rather in a moderate rate, and it has quite extensive first pass metabolism. So the doses won't retain. The slow release preparations, you have seen SR, verapamil, SR, diltiazem, they can be dosed once a day. So when you give IV, it's usually 5 milligrams to start with, and then you can repeat the dose. And then enterally, you can put the patient on escalating doses from 4 to 120 milligrams TDS to maintain the sinus rhythm. Right. So why this special mentioning about verapamil and digoxin? When you add verapamil onto digoxin, you have to reduce the digoxin dose. So these are few special things I would tell you in the lecture, but with practice, you will see a lot of other interaction. For example, in WPW, it is contraindicated, especially you don't combine a beta blocker and CCB in WPW. It can really work the other way around. It can precipitate VT and VF. And why digoxin dose should be reduced? Because verapamil displaces digoxin from the tissues and make the patient prone to digitalis toxicity. So you have to make sure that you reduce the digoxin dose if you are giving out, especially when a patient is on digoxin who comes to your ICU and puts out an tachyarrhythmia. If you give verapamil, you have to be very cautious. Diltiazem, similar to verapamil, but it is smoother in action. It causes less bradycardia than verapamil. So diltiazem, again, a good IV drug, very fast action, very good in where it is indicated. So unclassified drugs, adenosine. It is an endogenous nucleoside. So adenosine is a part of ATP, right? So it has a rapid onset and ultra short duration of action. So if you don't see response to adenosine, that means it has failed. It should be quick. So how do we give it in SVTs? If you fail to control the SVT with your physical maneuvers like Valsalva maneuver and your carotid massage, you can give adenosine. That is for your SVTs. But the doses, they differ. 6, 12, 12, 6, 12, 18, and 6, 12, 12, you can give as repeated doses. Just within minutes, you have to see the response. If not, it means that it has failed and warrants further repeated doses. So SVT is the main indication for adenosine. Dose is 6 and then 12. This is older version, 6, 6, 12. Now it's 6, 12, 12. And some they say 6, 12, 18 even. So when you give adenosine, patients feel a big discomfort. Some of you would have given it to the patients, and patients are like, feels like that I'm going to die. It's a bit of an uncomfortable feeling. So you have to tell the patient that you are giving this, and you have to accept that you might get these symptoms, but it is very effective. Right? Again, they can cause bradycardias, transient asystole. So be careful with all these drugs. As you give them, you have to make sure that the patient is in a well-monitored environment. What is the main clinical contraindication for adenosine? You always have to ask for history of bronchial asthma. But clinically, even though we say in theory, we haven't seen any bronchial asthma patient getting worse with adenosine. So you can actually clinically try it on patients. But theoretically, you should avoid adenosine in bronchial asthma patients. Digoxin is a cardiac glycoside. It inhibits sodium potassium. It doesn't come under any Vaughan classification theme because it has a lot of other activities. It has negative chronotropy by increasing vagal activity. So it cannot be classified under Vaughan classification. So it slows your heart rate, increases the force of action. Other non-cardiac effects are prominent: nausea, vomiting, diarrhea. So what are the indications? Rapid and persistent AF or flutter. So flutter is something, AF we know to some extent with evidence how to manage, but flutter is something we really don't know how to manage. So flutter has a lot of options to be tried with. Right, you can give it as IV doses, IV to start with, over 30 minutes. So it should be a slow infusion. And then repeat it 6 hourly until effective to a maximum dose of 20 mics per kilogram. Then enteral followed by maintenance dose. You have to halve digoxin in renal insufficiency. It's renally excreted. So digitalis toxicity is known to precipitate any form of arrhythmia. So make sure that you don't overload the patient with digitalis. What is the iron you need to monitor? It is potassium. So when the patient is given digoxin, if the potassium is low in that patient, digoxin toxicity is increased. Why? Because there is reduced competition at the potassium binding site. Both potassium and digoxin compete for sodium and potassium ATPase. When you have low potassium, your therapeutic dose can be toxic because you have low potassium, less potassium to compete with the digoxin. So digitalis toxicity can occur, especially with concomitant diuretic therapy, which can reduce your potassium concentration. Okay. Magnesium sulfate. What is the main indication? So your Tosades Dipointis, the drug of choice in TDP. So be familiar with these ECGs to identify them. So magnesium sulfate is mainly for ventricular arrhythmias, especially TDP. These are old, this is the old algorithm, adult tachycardia algorithm. These are the 4 features I talked to you about, but this guideline is now changed in 2023 ERC guidelines. So please download them and see adult tachycardia and bradycardia algorithms. So bradycardia, I will start with the algorithm. This is more or less the same. So the drugs involved are these. The first choice in bradyarrhythmia, like you monitor ABCDE approach. Then you see for life-threatening signs. These are the same as in tachyarrhythmia. I told you shock, syncope, myocardial ischemia, and heart failure. If there are no signs of life-threatening emergency, You can opt for not giving atropine even. So this is less than 60 per minute bradyarrhythmia. And you assess if there is risk of asystole. Now, heart rate less than 60, and this patient doesn't have any of these, you again assess for the risk of asystole in the coming hour. That is, if the patient has a history of recent asystole, Morbid's 2 AV block, complete heart block, and ventricular pauses. If you have these, you again give the drugs. What is the drug? First choice, atropine. So we'll talk about atropine. The mode of action is that it is an acetylcholine blocker, parasympathetic antagonist. So they block parasympathetic receptors at multiple sites. So it enhances the enhances the SA node automaticity, because SA node is, by physiology, it is kept inhibited by this parasympathetic outflow. So when atropine blocks that, SA node acts better, right? So sinus bradycardia is one indication, ineffective in the management of higher degree blocks. So because it acts at the main action is manifested at the sinoatrial node, higher degree blocks like AV blocks or complete heart blocks, it has little activity, effect, right? So you give it as IV 0.5 milligrams. So total dose is 3 milligrams. If that is not acting, you have to go for other drugs. What are the other drugs? Atropine, repeat to a maximum of 3 milligrams, isoprenaline, adrenaline, and your transcutaneous pacing. So how does isoprenaline is available at some, at some periods, during some periods, but most of the time it's not available. But it's a very, very good drug which can be given as a IV infusion. So if you have it, don't wait until your temporary pacing gets inserted. Give your atropine, call your cardiology team, and back. In the meantime, get hold of an isoprenaline vial and start them off on isoprenaline. So read upon isoprenaline how it is given. Right. So AF, just how we do AF management, only we will talk about, because that is the most common arrhythmia in the ICU. How do you do it? So this is basically, you have to go through the ALS guideline of managing peri-arrest arrhythmias. They have a separate guideline for tachyarrhythmias and another one for bradyarrhythmia. So ABCDE approach should be practiced whenever you get a patient with arrhythmia. When nurses call you at 1 o'clock in the night, don't just go and flush some amiodarone, right? So just start your ABCDE approach. Of course, that is how you detect those signs of decompensation, your heart failure, your syncope, your hypotension, and your ischemia. So start with your airway, right? So when you detect, if you have these 4 signs of instability, opt for synchronized electrical cardioversion, direct current cardioversion. So get familiar with your defibrillator, which you have in your ICU. Just see how the energy levels it has, the knobology, and just follow the pathway of checking it daily. Nurses would be doing it, but you also do, and get familiarized with your machine in the ICU. So this is the overview. This is how you would answer a question. So you start with ABCDE approach. Now this is the emergency. If you detect any of these during your ABCDE, and according to the new guideline, I told you extremes of tachycardia, 250, 280, go for synchronized cardioversion. Then you try to find the underlying cause. There are many causes in critical ill patients which can lead to tachyarrhythmias or AF. Main ones are your hypovolemia, fluid depleted, electrolyte disturbances, potassium, calcium, magnesium. Ask for those reports. Just do an ABG and see how his potassiums are. Some machines, they give calcium. Sepsis, treat your sepsis, correct your hypoxia, detect ischemia and treat. This is all of this is while you're treating your arrhythmia. And then maybe not really related to ICU patients, but if they are really thyrotoxic and in crisis, you have to treat that as well. Then decide whether to go for rate control or medically cardiovert the patient. And also in AF, you have to think whether you need anticoagulation prior to your cardioversion. That is why for atrial fibrillations, which we don't have a time of onset. Now the patient is coming from a medical ward, no one knows when the AF started. Sometimes we can predict, and if the two teams agree, we can take it as less than 48 hours. But if the duration of AF is more than 48 hours, you never cardiovert a patient, right? So you try to manage with rate control. And anticoagulation, always in long term, you have to get these scores on board, CHADS2 VASC score, to give a score and see if the patient has a score of more than 2 and more than 3 in male, more than 2 in females, as I remember. So if the score is high, you have to anticoagulate with warfarin long term. What is Hasbled score? That is the score which determines the risk of bleeding with warfarin. So that also has to be determined in coagulopathic patients before you start with long-term anticoagulation. So rate control or cardioversion. Now this is for the patients who are not unstable with those 4 factors, right? So you go with rate control if the duration is unknown. So we'll talk about electrical cardioversion. Now we know. Now electrical cardioversion, cardioversion, electrical or chemical, we should consider when the patient is not, now let's see the patient's instability we have checked. Then we have to see whether it is rate control or cardioversion we are going to give. Now electrical cardioversion is reserved for people in the emergency situation where they are unstable. Now let's say stable patients, still we can think about electrical cardioversion, but in non-emergency setting, either chemical or electrical. But if the AF onset is unknown or the AF onset is more than 48 hours, you have to do a transesophageal echo to exclude the presence of an intraatrial or appendage thrombus, because in chronic AF, they tend to clot blood inside this appendage. So if you have a thrombus in the appendage or left atrium, if you cardiovert this patient electrically or chemically, there can be this clot dislodgement and shooting of thrombi into your cerebral circulation or elsewhere. So we have to be very careful in cardioverting prolonged AF patients. So you can mention it in your answer and discuss how you would proceed. So the safe option in these patients where the onset is unknown is the rate control. If the AF is new, like you have just witnessed the AF, you can use either. If the patient is unstable, you can use electrical cardioversion. If the patient is stable, you can opt for either beta blocker or amiodarone. Right? So even though we use any of these, none of them would be effective until you correct the underlying cause. Right? So previously, everyone believed that rhythm should be controlled, but it is challenged now. Long term also, there is no clear survival benefit between the two arms. Right? Because now some studies, they favor rate control because they have seen a favorable response, a favorable result in rate control cohort with regard to death, stroke, and recurrent hospitalization. This is long-term things. So just you can mention that. So why rhythm control is not superior to rate control, which was the belief earlier? There had been no trials. And rhythm control was superior because those trials have included elderly high-risk patients. So there are different reasons why sinus rhythm is difficult to achieve. Even though we give rhythm control, sinus rhythm is difficult to achieve. How many patients we are seeing, right? Slow AF patients, they never achieve sinus rhythm. So likewise, the old belief is now not uh, held anymore. Right? These are the studies. So rhythm control. When would you opt for rhythm control? If you have LV dysfunction, now young patient, new onset AF, you would try with a bit of beta blocker. Elderly patient, LV dysfunction, you can opt for medical rhythm control with amiodarone because it has a mortality benefit as well. Now, younger patients less than 60 years, especially with structurally normal hearts, again, rhythm control can be used. But if it is a very transient thing, why would you put the patient on long-term amiodarone, right? You try with some beta blockers and the underlying cause is correct. The cause is corrected. Patient should usually revert back to sinus rhythm. So these are the drugs, acute drugs. So beta blockers, metoprolol 2.5 milligrams to 5 milligrams, esmolol, or you can give verapamil. Unstable patients, hypotension, heart failure. Still, if you are now, let's say you have cardioverted, again you can consider these drugs if the patients are resistant to electrical cardioversion. When you see the tachyarrhythmia guideline of ERC, the latest one, it also suggests to go for amiodarone if it is not responding to 3 attempts of cardioversion. Right. So that brings us to the end of the lecture. If you have any questions, you can ask or post in the chat, or you can email. You need to read more on, just read on common drugs, and it's a must to read the peri-arrest arrhythmia guidelines, the latest one, which is in the ERC. And see patients, always do not forget the basics, ABCDE approach, and how would you treat an unstable patient with the tachyarrhythmia or bradyarrhythmia, and then treating the underlying cause, and then the drugs, interactions. Apart from that, other things we can do, the pacing, transcutaneous pacing, the skills. Yeah, that's it. If you have any questions, we can discuss.
Madam, a quick question. You mentioned madam, can you hear me?
I think you went mute, again mute. You're
Can you hear
muted,
me now?
right? You're mute. Now, but you're muting yourself from time to time.
How is it now?
I don't know. Once you stop talking, you go mute. It's okay. Just ask your question. You're mute again.
So the question was, madam, you mentioned that amiodarone can cause tachyarrhythmia. So at that point, how would we differentiate between an amiodarone induced tachyarrhythmia or failure of
Usually,
amiodarone?
yeah. So, yes. The issue is amiodarone, it's more or less, it is not very common, first thing, amiodarone causing a tachyarrhythmia. The more common phenomenon is clinically. What is evident more commonly is patients going into bradyarrhythmias. Usually, when you use it first time on a patient, it drastically goes down, and you might have to cut down on your rate. But your question, how to differentiate, I don't have an answer. So if it is not responding, probably if what the literature says is when amiodarone-induced tachyarrhythmia occurs, the morphology of arrhythmia changes. It might go into a ventricular form, but not now. Let's say we give amiodarone to an AF, it might change its morphology. But if the tachyarrhythmia persists after amiodarone and it is due to non-response, it remains the same in the same morphology. So I have seen patients who, however much we give amiodarone, the AF persists. That could be that we are missing this unstable nature. For example, this patient, most of these patients are on noradrenaline, right? Or whatever the blood pressure, whatever is the blood pressure support, they could be, almost all these patients are on some form of a pressor. That itself means that these patients are in shock. So that is an indication to electrically cardiovert. That is non-response. Non-response, most of the time, it remains in the same morphology. If amiodarone induces a tachycardia, it changes its morphology most of the time. That's what they say. But I'm yet to see a patient with amiodarone-induced tachyarrhythmia. A lot of bradys, but not tachys, and lot of non-responders. That is, as I said, you're missing some point out of those four. Either the patient is in ischemia, hypotension, because regardless of the monitor blood pressure, if your patient is on a considerable amount of NORAD, that itself says that you have to cardiovert, not to go for amiodarone. That is the most common cause of non-response, that you have not detected the feature of instability like hypotension, ischemia, heart failure.
Right, and that brings me to my next question, madam. Where so in a new arrhythmia detected in a patient who's already any patient who's sedated or patient on pressors, where we won't detect signs like syncope.
Exactly.
There, how would we address that? Do we have a lower
Yes.
threshold for cardioversion there?
Yes, yes, clinically, of course. That I would totally agree. So these algorithms are for any of your patients, for ward patients, for HDU patients. When it comes to ICU patients, even the arrest detection changes, right? It's not the usual way we detect the arrest in a, like, for example, cardiac arrest in an ICU in a patient who is intubated, where we cannot confirm loss of breathing, and responsiveness where the patient is already sedated. Likewise, in an ICU, the context is changed. So you have to have a low threshold, and ischemia, you cannot ask for chest pain, right? Syncope, you cannot ask. Already they are sedated. So syncope is most of the time out. This, you might get an HDU patient. So you have to know the algorithm. That is one thing. So you might get an HDU patient now. It's not always level 3 patients we have. We have level 2s. So they can go into an arrhythmia. So you have to know to check for syncope and check for verbal ischemia. But in a level 3 patient, you have to have a low threshold. You have to auscultate your lung bases. You have to go through your notes. You have to see your chest x-ray, your EF, or you're already in heart failure patient. If they get a arrhythmia, better to cardiovert. And yes, chest pain, you can never ask. You have to get a ECG promptly. Syncope, you never can decide. So hypotension, already on a NORAD, I would always go for cardioversion, because with one shock they revert. And this should be a new thing. New, for example, AF, it should be new.
Right.
VTs,
Thank you, ma'am.
we get a lot of VTs, right? We get a lot of VTs because they have a lot of risk factors for VTs. So response very well. Because yesterday we had to, we didn't have to shock her. She's a vasculitis patient, came with pulmonary hemorrhages, not lepto. Now today she got her P ANCA positive. So she was in AKI. She was started on plasma exchange because of this thing, pulmonary hemorrhages, and she was ventilated, sedated. Now, during the second plasma exchange, once she was connected to the machine, and once they started infusing, took the blood out to separate plasma, and they had started giving FFP, suddenly she went into a VT. Her cardiac status is very good. All cultures negative. She was not on NORAD. She was not on NORAD. So she was otherwise well. So then it suddenly went into a brady, for which the reason until now we don't know. we had to give, very fast brady, tacky, VT, or some unknown ectopics, and then maybe some anaphylaxis too. So these are the things you have to practically manage. Very sudden, in front of my eyes, she went, and the
respiratory weakness, so he
transfusion
was
physician, she went
transferred to
into
the ICU
brady, and then
required mechanical ventilation.
peri-arrest brady, we
And
started
there were
CPR,
medical
2 cycles, adrenaline, that was non-shockable. The rhythm was PEA, first cycle. We had to give adrenaline, then she recovered. Now she is doing well with ongoing TP for the 3rd time. So these are the things you have to really be familiar with your, more than the side effects, I would say. Side effects you have to think, but you will be doing night shifts. You are the ones who are carrying out the ICU as housekeepers. So you have to really, you are the ones who are there to manage this emergency. So make it a point that you are very familiar with your ERC guidelines, peri-arrest arrhythmias. So most of the time you might have to combine all this, because the patients are not coming from the textbook. They can do whatever they want to do. So you have to have your knowledge at hand to change according to the situation. And at the same time, we need to, now we checked for her potassiums, we checked, she was dialyzed as well. And she was even fit for HD. She was not on CRR because we don't have CRRT solutions these days. So you have to be vigilant about the fluid balance, electrolytes daily. So everything is arrhythmias. There is an underlying cause, most of the time, not a cardiac cause. Non-cardiac causes are really abundant in critically ill patients. So make sure that you correct them while temporarizing your measures with antiarrhythmics.
Right, thank you, madam.
Okay. If you have any questions, you can ask. If not, we can wind up the session. Okay. Right. Okay, thank you then.